Greetings and welcome to Oral Pathology 360 OP Tuesdays. And today we have an oral medicine session, an oral medicine and diagnosis session. If it's your first time here, well, Oral Pathology 360, as the name implies, started out to promote oral pathology, but we have gone on to include all the diagnostic sciences of dentistry. And every week we have a live stream. Sometimes we have a recorded session on Tuesdays. The timing is given if you follow us or if on any of the social media or even visit our website, you will know the timings or you can subscribe here. Now, coming to right. So, sorry for that. There have been some updates on our website. And now it is possible for you to contribute to our activities both in a monetary way where everything costs. And so far, I'm supporting this entirely on my own, but I need to build it up so that we can pass it on to someone else eventually and have a bigger group that can continue with this work. So you can contribute. You can even contribute right here by hitting on the super chat or the super thanks, either on the current video, on the live video, or later on a recorded video, or then from our website there is a form and you can easily contribute in whatever currency you would like. And the small amounts will do as long as, well, it's often enough, let's put it that way. Coming to the next, there is also another little bit of news, and that is that we have, after a lot of people have been asking me, finally we have set up a training, a 6-month training for anyone who is interested. I'm hoping that some of our youngsters will join, but frankly it's open to anybody with an interest on the use of social media in promoting our health sciences. So basically it's a social media leadership training. It is free, but it requires dedication and actual work, and then you will get the certificate at the end of it. The form is on the website. If you just go to oralpathology360.com, you will find the academy and click on the academy and click on training. It will take you to the form. Be mindful that it will close at the end of November. Now, coming to today, yes, it's our first dedicated radiology session, and we have imaging of TMJ. It's always a little confusing to do a TMJ diagnosis, and it's fairly common, it's not particularly uncommon. So, so that's why this session, and we have Dr. Professor Ashwini Deshpande with us, and she's going to talk about all that is there to know on the imaging of TMJ. Right. Now, Dr. Ashwini Deshpande is a professor at Zydus Medical College and Hospital, Gujarat. She has a stellar academic career, many achievements, and she has a specific interest in TMJ. She has done a number of courses and done a lot of training for others on specially TMJ ultrasonography, which she will also be talking about today. She is also currently doing her PhD, and she is the assistant editor of our national, or the Indian Journal of Oral, Indian Academy of Oral Medicine and Radiology. With that, let me welcome her. Thank you, Dr. Ashwini, for joining us, and let me bring her in so we can all meet her for a minute before we proceed. Hi, Ashwini.
Hello, ma'am. Thank you very much for the lovely introduction.
You're most welcome. And welcome to Oral Pathology 360.
Thank you.
Yes. So, with that, I think we will just not keep everyone waiting and we will go on with the session. So, just for anyone who may be new, if you have questions or suggestions or thoughts, comments, whatever during the session, please type it in the chat and we will address all of it at the end. So, with that, I shall go on to the lecture now.
There are 206 bones in the body, and all of them go on to form 360 joints. This is from tip to toe. Now, of significance to the dentist, possibly the only joint of significance to the dentist, is the temporomandibular joint. Now, anywhere that you go and you try getting information about it, there is one thing which is very commonly said. So it is a complex and a poorly understood joint. Now, if you see the first picture on this slide, it is the write-up on the Mayo Clinic site. The second picture is of the John Hopkins University site. And the third and the fourth pictures down are TMJ groups, which they're organizations which help patients with temporomandibular joint disorders. Now, each of them, whether in the first line of the paragraph or uh, the first line of the second paragraph, they always end up saying that it is a complex and a poorly understood joint. Now, before we go on to how we want to image this complexity, let us first understand how we want to even diagnose whether it is a frank temporomandibular joint or not. Now, the diagnostic criteria for the temporomandibular joint disorders goes by a flow chart wherein first we need a proper history. We need to know where the pain is, we need to localize it, and then we go on to examination. Now, examination is routine where you're going to inspect, auscultate, inspect, palpate, and auscultate if required, and then we go on to a diagnosis. Now, it is very important that we differentiate myalgias and neuralgias from a TMJ dysfunction. Each of this is possible if you follow the flowchart that the IDC has given. Now, once we have decided that yes, it is a temporomandibular joint disorders, then we need to know whether it is an intra-articular joint disorder or a degenerative joint disorder. Now, again, there's a very clear flowchart, a history and examination. As much as the oral medicine, the oral pathologists and the surgeons would like to say, that is one thing which is 100% sure, there is no substitute for a complex history. You need to sit with the patient and get history, elicit history. Now, once we are going by the history, then we go on with a clinical diagnosis, and only then we decide if we want to even image. And even here, if you see, the last resort is the MRI, which is used as an imaging modality. Now, we should remember that in India, it is not so easy for us to get MRIs, especially in the 2-tier and the 3-tier cities. Now, this is despite us having, gone very far ahead in leaps and bounds in medical services. Medical services in India are great, but we still have a little bit further to go. Now, one other thing that everyone needs to know is you have a clinical and a radiological criteria for the most common presentation, which is hypermobility and internal derangement. Now, again, our clinical findings, there is no substitute to it. So we need to understand when the patient comes to us with pain, whether the pain is even originating from the temporomandibular joint. Now, how would we do it is, first we need to elicit what type of pain it is, where the pain is. This is a very good way of examination. This is given by Wilkes. And in this, they very clearly tell us that the stage of derangements of the temporomandibular joint are according to the symptoms that they present with. Likewise, the radiological findings are also according to how we expect to see it on the radiograph. This is a great article, and he is one of the best authors for TMJ's publications. Whether it is a in contradiction to other theories, whether he has devised his new theory, anyone who wants to read up should go and read up about G. Dimitroli. Now, once it was given that both clinical and imaging are very important for a temporomandibular joint disease, Dimitroli and a lot of other publishers came up and told us that you should also have a surgical classification according to stage. Classification, by classification I mean a surgical intervention and at what stage of disease. Okay. So again, if you look at this here, it is very comprehensive. Today's topic is only going to be radiology of the TMJ. So I'm going to only focus on that. Maybe the next few lectures could be possibly on one of the other categories. Now in imaging, what I want to see is I want to see where the disc is. Where the disc is going to be, whether it is fine in its place, whether it's anterior, whether it's posterior, whether it is causing changes in the condyle, or whether it is completely destroyed. That is one of the important things for internal derangement. Now, this again was given by Dimitroli, and you should remember Again, temporomandibular joint diseases are complex, like I have said before, but listen and read the third point, which is the clinical course of temporomandibular disorders does not reflect a progressive disease, but rather it is a complex disorder that is molded by many interacting factors. For example, in today's lifestyle, we are under stress, we are anxious, we are worried about what's going to happen tomorrow. So yes, all of this, it's like a multifaceted disease. So this is one very important thing that I wanted to bring to your notice. So for today, everything is going to be in gray, black and white. It can't be a single color. So let's learn what the So this is how the temporomandibular joint functions in complete normality. Okay, so you have the disc in between, you have the condyle below that, and you have the glenoid fossa and the articular eminence. Okay, these are the three, four things that you need to know. Now, one other important thing is to know that if it looks like this in actuality, this is how it looks on a radiograph. Remember, all radiographs, mostly the ones that you're going to see initially, are two-dimensional images of a three-dimensional moving structure. Okay, so this is how it will look actually, but this is only how much we are able to see on a radiograph. So if you look here, this is something called a tomogram. It's called a TMJ tomogram, which is available with all OPG machines and CT machines. And in this, once we get the image, we want to see where the condyle is. We can't see the soft tissue in any radiograph mostly. Now, once we see this, we want to assess whether it is going beyond the eminence or before the eminence. Left, you have the TMJ actually moving. To the center, you have a tomogram, and to the right, the similar thing in a dry skull. If you look at the images to the right of the screen, the dry skull is followed by a CT image. So a CT does not greatly contribute in terms of a TMJ tomogram in comparison to a TMJ tomogram. The MRI will only give us the soft tissue pathology. Now, now that we have seen the two-dimensional images, the other investigative modality, which not only sees normal anatomy, but it also needs a little bit of imagination, is the picture. Now, so again, to the left you can see a normal joint. See the same thing in a two dimension. Now look at the left of the lower picture, and this is how your ultrasound will look. Now this is how it will look in black, white and grey. But to the right, the marks that are drawn, those are the ones that you need to keep in mind when you're interpreting. So if you see on top, this is the articular disc. This is the head of the condyle. This is the masseter muscle in front. So now looking at its relation, you should be able to diagnose a disease. Now in any TMJ evaluation, before I decide what radiograph I want to take, we need to know what we expect to see. Now the first is we are going to decide first whether we want to see soft tissue or hard tissue. Most often we need an overlap of both. Next is we need to check in the soft tissue, do we want to look at the articular disc or the musculature around. In hard tissue, we need to check whether we want to see the head of the condyle. Now, if it is an articular disc or if it is even the position of the condyle, we need to take both an open and a closed view. Whatever radiograph you take, whatever investigation you do, I want both the views. Whereas if you're going to look at only the heart tissue, then you're going to look at both condyle morphology and the head of the condyle. It will surprisingly give you a lot of interpretive information. For example, look at this. Now, if you look at the video, this is how anterior disc displacement with reduction. Now, if you look at the ultrasound picture below, this is how I want you to look at this and then imagine it here. So this is where the disc is anteriorly, and this is what it becomes once the patient opens his mouth. So you know this is very clearly anterior disc displacement with reduction. This is slightly black, but the gray area, which is the disc, is somewhat anterior. Now, the other thing that you'll be able to see very clearly, even in an ultrasound or even in uh, TMJ tomograms, is a lot of orthodontists and surgeons are both the cause and the remedy of a temporomandibular joint problem usually. Once they are possibly doing ortho treatment or surgical treatment or whatever, it could result in an osteoarthritis sometime later on in their life, or it could happen even without any surgical or orthodontic intervention. Now, if we look at the OPG very clearly, if you look at the right of the OPG, the right condyle has the beaking of the condyle. The left condyle appears normal. Now, the same thing if I want to do an ultrasound, if you look at the right condyle, if you look, the posterior slope is very acute. And here the posterior slope is rounded. So you know that this is very clearly osteoarthritic change. Now, once we know that our patient clinically has a very common diagnosis, which is hypermobility, we are going to ask for a TMJ tomogram. Now, if you look to the left of this picture, if you look to the left of this slide, you will see that the TMJ on the left side appears absolutely normal, both the right and the left. Now, if you look at the right picture, the right TMJ, I told you, it should go only 2 mm beyond the glenoid fossa or beyond the articular eminence. Now, it is going well beyond that. So, this is very classically hypermobility. Now, if you look here, this is one ultrasonographic uh, video that I want to show you. I am also showing you the section that I showed you before, wherein it is going to show you anterior disc displacement with reduction. It's a lot of imagination, and it took me a lot of efforts and a lot of efforts from also the general radiologist to explain to me how to be able to interpret it. Now keep looking to both the left and the right of the image. So this is anterior. If you keep looking on this image, this is exactly what is shown in the right side. So the disc was present anteriorly and it snaps on, moves ahead with the condyle and snaps back out again. Investigation most often in, like I said, the 2 and the 3 tier cities of India, could only be an OPG and a tomogram. Now, in a tomogram, if you see, so if you look at the pre-treatment of this patient, a normal tomogram was taken, a TMJ tomogram was taken. See how far ahead it extends. Now, in the 6-month follow-up, seems to have settled. I think this patient was treated with prolotherapy, if I'm not mistaken, but the TMJ tomogram was more than enough to diagnose and treat the patient. This is again one ultrasound wherein the patient had very severe pain in the temporomandibular joint. Her mouth opening was okay, but she had a very collapsed bite, a slightly collapsed bite. Now, when we took the ultrasound, if you look at the video also, you will be able to see that there is absolutely no space. There is no synovial space at all. Look there, and this is the still of the same image. So there's hardly any space, which is why the patient had very severe pain. So this also is possible to diagnose even with just an ultrasound and a TMJ tomogram. The patient went ahead with the ortho treatment and is doing fine today. Now, this brings us to a crossroad where we need to realize that before we even initiate any investigative modality for the patient, we need to know whether we are going with hypermobility or an internal derangement. Now, hypermobility, the treatments usually are different. Internal derangements could be self-conclusive, wherein they may not need any treatment at all sometimes. But again, we are always usually at crossroads when we're trying to diagnose this. Um, this is, well, there is no substitute to theory and journals and textbooks. Now, I would like to leave you with this one point, which I like calling the rule of 90. Now, according to me, the rule of 90 is like it goes somewhat like this, wherein almost always the patient will report to you. You may not go looking at the patient, looking for the patient. He will report to you with pains and sounds in one or both the temporomandibular joints. Now, if you closely examine the intraoral cavity and you take a history or you look at the parent's genetic profile, by genetic profile I mean if the parents usually have a collapsed arch, the child also will eventually end up having an arch like that. So if you check very properly, you will have malocclusion as one of the reasons for all of this. Now, uh, like I said, 90% of all your TM joint diseases, if they are because of malocclusion, next I would very clearly say that 90% of all your temporomandibular joint diseases are hypermobility and intra-articular joint disorders. So you can be very clear about that. If you just sit with the patient for 10 minutes, get a proper history, examine him and thoroughly check him up, you will be able to very fairly easily say that it is probably a clear-cut case of hypermobility, which almost always happens. Now, in as many cases as I have seen, only the left side of the TMJ is usually involved, unless it is a compensatory mechanism where the right also may be involved. And like I said, as much as we would like to debate and say yes or no, the orthodontists and the surgeons are the cause and the reason for the success of treatment also. So it has been documented of late that both the treatments or treatment plans for diseases that they treat could result in a frank TMJ problem by itself. Now, in my experience, in all the places that I have worked, when I told the patient that my diagnosis for his complaint was a temporomandibular joint disease, my patient almost always refused when I asked for an MRI. Now, why this happened was maybe because of the cost. A couple of patients told me that they have been told that it's very bad for the eyes and bad for the body and whatever. So, either way, my patients eventually refused an MRI. Now, keeping this in mind, again the rule of 90, when I told the patient that I can possibly diagnose him with just a plain film radiograph, or maybe upscale it a bit and say that I want an ultrasound of the joint, they eventually agreed. So the rule of 90, if you keep all of this in mind, you will be able to diagnose a majority of your diseases. Um, this is a very short presentation going beyond temporomandibular diseases is difficult, but containing yourself just to radiology also is quite hard. I've given you clear-cut examples of each of the diseases that you're going to encounter and each of the diseases that you need to even investigate. There are things that you may not need to investigate at all. For example, if your patient doesn't have a complaint or the patient is not bothered or you notice that the patient doesn't want to treat it or whatever, then there's nothing that you can do. But if you want to diagnose diseases, then you need proper investigative modalities. Now, the first two pictures on top are pictures of a CT and an MRI machine. Now, as much as we would like to go with all of these things, in the end, it is always the TMJ tomogram, and for me, the ultrasound has helped a bit. Although the ultrasound is a little difficult to interpret, the TMJ tomogram has stood the test of time over so many years, wherein even now, even after look at the kind of material and the kind of investigative modalities that are even available today, we are able to diagnose with just a TMJ tomogram. So that solves more than half of our problem. I couldn't complete my presentation ever without giving a lot of love to the memory of my late father. Acknowledgments are absolutely due in this presentation because let me tell you that for a radiologist to take time out, spend it with me and try and understand the TMJ like I have understood or like she has made me understand. I owe a lot of gratitude to the first lady in the picture, Dr. Megha Jain. She is the one who has helped me understand the TMJ in over so many years. A lot of other people that I would like to thank, my Dean Tripathi sir and my CEO, who very easily let me barge into the radiology department without asking me any questions and told me that yes, please go ahead and do as you please. So we are able to do a lot of TMG investigations. Now, apart from the three people on the left, the first five people on top, the three people on the left, plus the first five, all of them are national and international figures in India. Now, Dr. Ashok, Dr. Mandana, Dr. Sivapatha Sundaram, Dr. Rajkumar, and Dr. Kritika, all of them have been my teachers in every which way. And even today, when I look back and see, I was able to become a good clinician because I was taught to be that way. And I was taught by example. When my madam used to sit with me and say that you have not taken a proper history, I realized that yes, we were lacking somewhere to come to a good diagnosis. Like I said, all of them are great figures, and it's been an absolute, it's been a blessing for me to have learned from all of them. The other four people on the lower part of the slide, Dr. Amit, Dr. Vikram, Dr. Silki, and Dr. Savita. Again, all of them are a bunch of dentists who are doing very well in their life, and they're just very kind and people who have stood the test of time for themselves and for us. So I would personally like to thank all of them today on this platform. Mandana ma'am, my special thanks to you because if you hadn't been so specific in everything that you wanted, I don't think I would have been so specific with my presentation now. Maybe on another platform we could spend more time with the TMJ as such, but I hope this suffices. I would like to extend my courtesy and my gratitude to the doctors who provided the skull pictures also. I would like to end by saying that the TMJ is a very complicated joint, but it is up to us to make it simple. And I hope myself, I am Dr. Deshpande Ashwini Suresh, I have been able to make it just a little bit simple for all of you. I'm available on mail here for whatever discussion that we need, but thank you very much.
Right. Thank you, Dr. Deshpande. That was indeed a very great presentation. So it's time for question and answer. Right. It's our time for question and answers. And that was indeed a very nice presentation. Now we already have one question. So let me just bring it on and you can take that. This is from Dr. Osmani Guevara. He is from Ecuador and he's asking which is the differential diagnosis between TMJ and muscle disorders.
Uh, Thank you, ma'am. And ma'am, the question, the differential diagnosis overlaps. It's only a matter of you being able to elicit history and examine perfectly, and maybe add a couple of investigations after we have gone past the first 2 points. Only then we will be able to perfectly diagnose. But it's a big overlap. In fact, the first slide that I had shown, the RDC criteria, sorry, very clearly says that the clinical investigations are only the third in line. So we need a history and your clinical examination before you can even come to even one of the diagnosis.
That is very true. There's a lot of overlap, even in the pain that is felt in the area that generally hurts. Yes.
Yes, ma'am.
Okay. And let me just remind everybody, I think a lot of our viewers today may be first time here. So please put in there's a live chat below your video, or even if you are on mobile, and you can type in your question there. We would also love to know where you're from. Did you like the lecture? What do you think? It'd be nice to know basically who's watching, so you can just put that there, put your thoughts. And okay, I had one question. Now you
Yes,
mentioned
ma'am.
that very often, as you were closing, actually you mentioned that very often you have found that the pain is on the left hand side, is on the left TMJ. Is that in any way related whether the person is right handed or left handed?
Bingo, ma'am. You hit the nail on the head. That is what my assumption was when I constantly saw a lot of. In fact, when exams are close by, I get a lot of students with two diseases. One is either lichen planus, and the second one is TMJ. Obviously, because of the stress of some sort. Now, as much as I have seen, like you said, we can attribute it to the right side of the body. Majority of Indians being right-handed and not being left-handed, it could be attributed to that, and that is what I am investigating. In fact, it's a study which is going on just to see the incidence of TMJ pain, whether left or right.
It's very interesting because I know that it's like the same way that we all, the right handed, we brush in the specific way, we also
Yes,
use one side probably more. And I also have this thought, it may not make sense, I don't know. But inevitably, one side of our mouth has more caries and more problems. Okay.
true, ma'am.
Whether it is then that the opposing side, because that side will inevitably be a little weaker and multiple problems, maybe food impaction, etc., that happens very often even after
Yes, ma'am.
restorations. So whether by default then we shift to the other side, I mean, these are just thoughts.
Ma'am, one thing that I noticed, especially when I was brushing my teeth, is I'm a right handed person. I first always start with my left. So if you see abrasion in a right handed person is always on the left. So they're probably not brushing and spending enough time cleaning that area.
Yes, exactly, that's what. So I mean, these are all just things that are rather interesting. Let's see. Okay, let's
Yes,
see, we
ma'am.
have some other comments. Do we have any questions? Hmm. No, I think we mostly have comments. Dr. Vikram Reddy saying excellent presentation, made it easy and simple to understand. Thank you for watching, Doctor. Dr. Rahul Shukla, thank you so much for providing us great knowledge about TMJ. Yeah, TMJ is rather difficult. Dr. Nidhi, very knowledgeable presentation. Thank you for making it simple and clear. Dr. Amit, excellent presentation. So it does seem like we do not have any questions. We just had everyone saying great presentation, and it is true. It was really a nice presentation.
Thank you, ma'am.
Um, yes, sorry everyone, there were little gaps in the recording. Those could not be avoided, but hopefully I will edit them out of the video by tomorrow. It won't be possible today, but by tomorrow it should be possible to edit them out. And I think we have covered everything.
Yes, ma'am.
Anything you would like to say?
Ma'am, I think me having chosen this date, we had a big discussion about the date. I was asking for a date much later. It worked out well because today is World Radiology Day, so it's a great way to start.
Wow, I did not even know that.
It
Okay,
is,
so
it is.
happy radiology to everyone who does radiology, yes. And
And ma'am, it was fantastic. I mean, I've given presentations in person, but giving it online was a totally different experience. And you made it very simple. And I told you this even in the morning. I said, "Ma'am, I've learned so much from you in just 3 days." So thank you.
this is nice. Thank you so much. Thank you. You were kind enough to include me among the people who have had an, sort of a influence on your career. And I don't really think I deserved it, but anyway, thank you very much
You
for
did, ma'am. You did.
including me.
You did.
I
I,
don't think
I
I have.
believe after having become a teacher, I realized that my teachers worked very hard with all of us and they deserve every little bit of credit that we can give them.
Thank you.
Ashok sir and all, not teachers when I was UG, but after I have passed out, I mean, he's been the person I go to in my academy always.
That's nice.
Yes.
Right. So let me, no, we do not have anything else. So let me, right, present you with your certificate with our gratitude. Thank you so much again.
Thank you,
It
ma'am.
was
Thank you so
really
much.
nice. Yes. I do hope we will have you back on the channel, and then maybe you can talk more on TMJ and on the actual diagnosis of the disease, of the range of disease conditions.
Will be a
That will be
pleasure,
also
ma'am.
very nice.
Yes,
Thank
ma'am.
you. So, with this, we have to move on to sharing with you what's coming up next week. So, next week we have an oral pathology session, which is about, it's always difficult to identify the kind of hard tissue we are looking at, whether it is cementum, bone, whatever cartilage. So, it is always good to be able to identify exactly which one it is by just a simple stain. And we have a session, a technology update session, which is on the stain, on Gallego stain. That's if I pronounced it right. I hope I did. And with that, I will say, well, thank you. And it was wonderful having all of you here. Do remember, if you liked the session, please hit the like. It's always good. And always remember, you can connect with us among in a number of social media locations, as you can see, whether it is on LinkedIn, on Facebook, and on Insta. The handle is OralPathology360. And then, of course, our email and website are there. It is wonderful to have had you here with us. Have a wonderful week, and we do hope to see you on coming Tuesday. Bye for now.